in working with our speaker, Lainey Dratch, to put together this presentation. I am very happy to introduce our speaker, our presenter, Ms. Lainey Dratch. Lainey is a licensed certified genetic counselor in adult neurology at the University of Pennsylvania in Philadelphia. She specializes in ALS and FTD, frontal temporal degeneration. You'd think that word you don't stumble upon, and you always do. Spectrum disorders and other neurodegenerative conditions, with a focus that bridges both clinical care and research. Lainey earned her bachelor's degree in neuroscience from Colgate University, graduating with high honors, the highest honors, and went on to complete her master's of science in genetic counseling at Johns Hopkins University and the National Institutes of Health. We're so grateful that you're taking your time today to be here to speak with us about the role of genetics in ALS. We welcome you. Thank you.
Thank you so much. Can you guys hear me okay? Is it coming
Yes.
through? Okay, wonderful. I'm really appreciative that I Am ALS invited me to speak to you all on this topic, and that I Am ALS is bringing this topic into the fold of material they're covering. I obviously am quite biased, but I think it's a really important topic for everybody to think about. And so hopefully everyone gets the chance to learn something new today, or hear something that they feel is valuable. So I'm going to go ahead and start sharing slides. Let's see. Screen. Oh, let me first put it. I did this before. Let me present first, and then I will share that screen. Okay. All right. Is anyone able to verbally confirm for me that you can see the slides?
Yep.
Okay, perfect. Thank you so much. So, as the lovely introduction covered, today we'll be going over some of the key things to know about the genetics of ALS, regardless of whether there's family history. And so, just a few disclosures. I've done some consulting, but none of that should conflict with what I'll talk to you about today. And so we'll go through some of the key things to know about the genetics of ALS, some frequently asked questions about genetic counseling and testing, as well as logistics for how to access this. And then I'll have some resources, and we'll have time for Q&A at the end. Just a few terms in case they're less familiar for you all. Obviously, ALS is something you are all familiar with if you found us through the I Am ALS organization. But as we mentioned briefly before, FTD, or frontotemporal dementia, is also called frontotemporal degeneration. So you may hear me refer to FTD. If you see AD or PD, those refer to Alzheimer's and Parkinson's respectively. So what do we know about genetics in ALS? Some of the answers to that as a big question is that for most people with ALS, we actually don't have a single genetic difference that explains why they've developed disease. There's not one single genetic cause, but sometimes there is. When there's not a single genetic difference that's driving disease, we usually describe the cause of disease as multifactorial, which simply means that there's multiple factors, more than one reason, contributing to why disease developed. And those can be a wide variety of things like environmental exposures, lifestyle factors, teeny tiny genetic risks that don't in themselves cause disease, but combine with other risks to cause disease. And what we're not that good at right now is for any one person pinpointing what are those multifactorial causes in you. The chances of there being a genetic cause for ALS depend on certain characteristics. We'll talk about family history because that's one of the main indicators, but not the sole indicator. Sometimes age of onset and rate of progression can give us clues. And it's really important to have an accurate diagnosis to guide the most appropriate genetic testing. And sometimes there can be conditions that have overlapping features with ALS, and so that can influence whether or not there's a genetic difference at play. And so just as a quick refresher before we dive deeper than that, I know that not everybody thinks about genetics every day the way I do, so I want to just refresh on what do we mean by genes and genetics. So if you think of the DNA code that you were born with as sort of like a string of letters that spells out an instruction code for the body, we know that sometimes there can be differences in that instruction manual. Quite literally, letters can be changed in that DNA code, and sometimes those differences don't cause any problems, but sometimes changing just one single letter in that code can change the meaning of the instruction for the body. So if you think about it as the sentence, the hip and the leg, if you switch just one letter, you can tell the body the hip and the peg, which we know is quite different. And so sometimes there can be single letter differences in the DNA code that can have drastic impact on the instructions for the body and can sometimes cause disease. So we know that when you think about ALS as a whole, about 10% of people with ALS have a known family history of other people with ALS or conditions that can be related. When that's the case, we can find a genetic cause about 75% of the time. So for most people who have ALS and have one other family member or more than one other family member with ALS or related conditions, we can usually find a genetic cause. But for the vast majority of people with ALS, about 90% of people, we don't have a known family history of ALS or related conditions. And so historically, those people were told, you don't have family history, it's not genetic. But as more research has been done, what we've come to learn is that more than 10% of people in these scenarios still have a genetic cause that we can find on today's testing. And so, what I'll unpack next is what do we mean by related conditions when we're talking about family history, and why might family history not be the whole story here? So, you've heard us now a few times say the word FTD or frontotemporal dementia. This is something that has now come to be understood as having an overlapping spectrum with ALS. So we now know that there are some genes that can cause ALS in one person, FTD in another, or sometimes symptoms of both in the same person or within the same family. And so because there's this underlying biology, the genetics, and the protein that's building up in cells in the body, often TDP43 is the name of the protein that's gone, haywire in the body. We now have understood ALS and FTD to be connected because of this shared biology, both in terms of the proteins and the genes. And so for some of you, I imagine you might not have heard of frontotemporal dementia because it's not a super common condition, though it is one of the most common one of the most common types of young onset dementias. In fact, in people with young onset dementia, talking about the 40s through 60s as the age of onset, it's just as common as early onset Alzheimer's disease. And so frontotemporal dementia is quite different from Alzheimer's. Instead of presenting with changes in memory and confusion and problems recognizing people, FTD presents with changes in behavior, personality, or language, sometimes movement, and again can have overlap with ALS. And so FTD can look quite different person to person. It can look like people being quite different from their baseline personality, and people can get misdiagnosed with things like depression or bipolar disorder or OCD because the symptoms can mimic those things. And so it's possible that somebody could have ALS and have nobody else in their family tree with ALS, but have other people that have symptoms that are, suggestive of FTD, even if it wasn't diagnosed, and that could increase the likelihood of finding a genetic cause. And so I mentioned that family history doesn't tell the whole story, and part of that's because family history is a limited tool. So I just mentioned one example of a limitation, which is that if you're asked if you have family history of ALS, the answer may be no, but there could be other related conditions that you might not have even known about in your family, like frontotemporal dementia or Parkinson's or early onset Alzheimer's. So sometimes there can be missed patterns because not everybody presents the same way. But also, these are tricky things to diagnose. It can take a long time to get a diagnosis of ALS or FTD. And so people may pass before they get the right diagnosis, or people might not ever make it to the right doctor or might not share that information with the family. People might have a small family to begin with, or people may not know too much about their family history. People could die young of other causes, right? These are adult onset conditions. If people die in their 40s and 50s of cancer or heart disease or other things, who knows if they would have developed neurologic disease if they lived longer. And also, this concept of penetrance, which is something I think is important to talk about because it's been in the literature and in the social media and other buzz lately. Which penetrance is a term that means if I have the genetic difference, what's the likelihood I actually develop symptoms someday? And so there are some people who will have a genetic form of ALS in their family, and it might have been running through the family for generations, but not everybody who had that genetic variant went on to get symptoms. And so that's another way that family history can be masked. So when a person has ALS and no known family history, that does not mean it's not genetic, and it's still important for you to consider is genetic information something worthwhile for you to gather? And we'll come to talk about, what can it tell us in a few slides. Just a little more background here. So we know that there have actually been over 30 genes implicated in ALS and FTD spectrum disorders. Some of the discoveries go back to the early 1990s and continue all the way through today. We're constantly linking new genes to these disorders. But the most common genetic cause of both ALS and FTD is the C9orf72 repeat expansion that was identified in 2011. But we understand now that how common certain genes are in causing ALS vary based on your ethnicity. And so where you're from in the world can also influence how likely it is that we'd be able to identify a genetic cause for your symptoms. We know a lot more about the genetic causes of ALS in people of European ancestry because those are the populations that have been overrepresented in research. And we need a lot more work to try to better flesh out what are some of the genetic causes in people from non-European backgrounds. So hopefully that is an area that we see more research in soon. If there is a genetic cause found for ALS, most of the genetic forms of ALS are inherited in what we call an autosomal dominant pattern. Autosomal means that it affects people of either sex. It doesn't matter your sex in terms of whether you can develop symptoms and how you can pass it on and who's more at risk. It has nothing to do with the sex chromosomes. Dominant refers to the fact that you only need one of your two copies of the gene to not be working properly in order to cause symptoms. So in an autosomal dominant condition, each time a parent has a child, the affected parent has a 50%, so a 1 in 2 chance, to pass down that genetic risk to a child. How likely it is for that child to develop symptoms someday, again, depends also on the penetrance. So we may be able to say there's a 50% chance that this is going to be passed down in each pregnancy, but what are the odds the child actually develops symptoms depends on the specific variant. And we talked before about multifactorial inheritance. If we don't find a genetic cause, most people fall into this multifactorial bucket. I like this jar model. If you think about you have to fill the jar up in order for disease to develop, we're all born with different risk factors. So you can think about those little yellow balls. We're all born with some level of genetic risk, but we may have different levels of those blue triangles, the environmental factors. And sometimes you may have a moderate sized yellow ball that isn't itself enough to fill the jar, but may increase your risk more. You can also think about protective factors, things that make your jar taller, things that increase the size of that lip. And so these are all things that are active areas of study. And so most people who don't have family history of ALS will fall into multifactorial inheritance category, but again, more than 10% of people will fall into the genetic forms. And so a lot of people talk about sporadic and mean it in different ways. And I have a bit of a soapbox about the word sporadic. I kind of hate it, to be honest, and that's because it leads to a lot of confusion. Sometimes people use the word sporadic to mean not genetic, and sometimes people use the word sporadic to mean no family history. And those aren't the same thing, right? Because I just told you can have no family history, but still have a genetic form. And if we're talking about sporadic as in not genetic, that's actually really hard to prove, because even if we test somebody for all the known genes we know about now, what's to say that there's not going to be a new gene linked to ALS in the future, right? So even a negative genetic result isn't completely meaning sporadic. So I kind of hate this word, but I will still talk about the difference because it is something you'll read about in the literature and whatnot. So symptoms alone don't distinguish whether somebody has sporadic or familial or genetic ALS. The symptoms aren't enough to distinguish this. Sometimes, again, family history is used to help distinguish what's the likelihood we would find a genetic cause, but it's not a perfect distinction. You can still have a genetic form with no family history. And sometimes people ask, hey, if I had an autopsy, if people looked at my body after I passed, would that help them figure it out? And sometimes there can be clues based on what proteins are building up and where, but that often is also not alone without genetic testing to really distinguish whether this is genetic or not. And so the real reason or the real method to figure out is there a genetic cause here is by undergoing genetic testing. So now we'll turn to talking about who can access genetic testing and what are some of the considerations here. So when I think about genetic testing, I think about two main buckets: diagnostic, also called symptomatic, and predictive testing. And today we're focusing on diagnostic. This is for a person who has a diagnosis or suspected diagnosis or symptoms of ALS, undergoing genetic testing to try to figure out why this has developed. And so recently there have been several publications that have come out that have really emphasized the importance of offering genetic testing to anybody diagnosed or suspected to have ALS early on in the disease course. And I'll talk to you a little bit about some of the reasons why. But importantly, these led to published guidelines, evidence-based consensus guidelines by my colleague Jennifer Rogenbuck that outlines exactly that. Everybody diagnosed or suspected to have ALS should be offered the opportunity to have genetic counseling and testing. And it specifically outlines the genes that should be included if testing is pursued and what a genetic counseling visit should entail. And so, some of the reasons that we now feel that everybody should be offered the option to have counseling and testing include some of the benefits of testing that I'll go through in a few slides, as well as some of the therapeutic advances that I'll go through as well. Before I jump into that, I want to just briefly touch on the predictive testing realm here, because again, that's not going to be the focus of today, but it is a type of genetic testing. And so a lot of people ask, if I go through genetic testing for ALS and a cause is found, should I share this information with my family members? Is it just going to scare them? What's the point? Why would I do this? But we as genetic counselors would argue that you should communicate this with the family, and actually that, you can start those conversations even before testing is pursued to help, let them understand how your results could have influence on them. And this is what makes genetics unique compared to other types of evaluation, right? You're getting information for you as part of your care, but because it's genetic, it could have implications for children, siblings, extended family. And so people who are family members who may have genetic risk might want this information to be proactive. If you give them that information, it doesn't mean they have to have testing or do anything with it, but you've given them that knowledge and the ability to think about it. And they may be able to access resources. And it's been found in the literature time and time again that if you don't disclose information to family members and they later find out, there may be resentment or anger about not having that information earlier to use it in the way that they wanted to. And so this again is predictive testing where you're a person who doesn't have symptoms looking to see if you inherited risk for future symptoms. And so some of the considerations of why a person at risk may want this information is to use it to think about different reproductive options, to have kids in a different way to avoid passing down risk. They might want to just have an answer to reduce uncertainty. Did I inherit risk or did I not? They might make different decisions about their career, their retirement, their financial planning, where they want to live, if they want to be near family, what kind of home they want to live in terms of accessibility. There may be kids that they have already that they want to provide information for. There might be clinical trials or, other research opportunities they might be able to join. But there may be things that keep them from doing this or other considerations that, may make them less eager to test, like how will this impact me emotionally living with this knowledge of potential risk? And, is this going to impact my relationships with my family or my significant other or significant others in the future? There's nothing currently to completely prevent developing ALS, but people might be able to meet with neurologists and have monitoring and access care in ways that are meaningful to them. And people may be concerned about insurance and privacy and discrimination. There is a law called GINA, the Genetic Information Non-Discrimination Act, that provides some protections against discrimination, but does not provide protections against all insurance types like life insurance, long-term care insurance, disability insurance. And there's some other loopholes as well. And so there's a lot of uncertainty even with a positive result. Again, what's the likelihood I would get symptoms depends on the penetrance of the specific variant. We wouldn't be able to tell people how old they would be when they develop symptoms or what exact symptoms they would develop. And it creates this sort of patient and waiting concept of I'm a healthy person and I know when I inherited risk, but I'm not yet sick. And that can be really challenging from a mental health perspective. But people may be able to access neurologic care. They may consider having clinical monitoring or participate in research. And so as a person with ALS considering undergoing genetic testing, it's important to think about what implications this could have for a family. And so these are some of those implications. But really, I want to focus on what can genetic testing tell you as a person diagnosed with ALS? Why can this be helpful for you? And so the main reason that we have now come to this point of having guidelines suggesting that every person with ALS should have the option to undergo counseling and testing if they want it is because we have entered the era of genomic medicine in ALS, which is pretty incredible to be able to say. In 2023, the FDA in the US granted accelerated approval for tofersen, which is the first gene-targeted therapy in ALS. This is an incredible feat. We now have a targeted therapy for individuals affected with a specific genetic form of ALS caused by the gene called SOD1. And this was actually the first gene linked to ALS back in the early 90s, but it only explains a small proportion of people with ALS. Only about 2 to 4% of all people with ALS have an SOD1 variant. And so we have had incredible data so far coming out of the tofersen program, and it will be exciting to see, where it goes. And there's a lot of other genetic targeted therapies in clinical trials right now. And so we're learning from the experience of this first one out the gate, and there will be others coming soon. And so in order to access a gene targeted therapy, you have to know your genetic status. And because I just told you that family history alone does not distinguish between people with a genetic form and people without, we have now said that all people with ALS, regardless of family history, should have the option to be able to access genetic testing if they want it, because we have a gene-targeted drug approved, and you cannot access that gene-targeted drug unless you have your genetic testing completed and you're found to have a difference in that gene. And so, regardless of family history, there's a chance you could have a genetic difference in this gene. It's more likely to have a finding in this gene if you have a family history, but we have had multiple people, even in our own clinic, who have had ALS, no known family history, and a difference in SOD1 found on testing. Beyond access to approved therapy, the other reasons that we have now argued that everybody should be offered genetic testing is because there's many benefits of genetic diagnosis beyond treatment. I already went through some of the information for the family, how this can be beneficial to other individuals who could be at risk. But for the person diagnosed, it can also help solidify an ALS diagnosis. We know it can be incredibly difficult to make a diagnosis of ALS because it's a diagnosis of rule out. There's a lot of other conditions that you have to rule out to say we think this is ALS. And there's not one test that in itself is a sole, yes, this is proving ALS. And so adding a genetic variant into that set of data that the neurologist is considering can certainly help them in their sort of confidence in making an ALS diagnosis and can help avoid some other, costly and invasive procedures. And so this can also help us provide you with more information about what to expect for the future. We can tell you, based on this genetic finding, here's what other people have tended to experience. Is this a gene only associated with ALS, or is this also potentially increasing risk of FTD or Parkinson's or other symptoms? And we can help you then anticipate, future medical needs. We can get you more targeted access or more access to targeted support resources and advocacy groups. We can help you find gene-specific content and community. We can also, even if it's not an FDA-approved therapy that, you can gain access to, there's tons of clinical trials ongoing and tons of observational studies that you might be able to gain access to. And for some people, they just want to know, why did I develop this disease? And so having a genetic answer can give some relief to just understanding why this has developed. And so, yes, there's an FDA-approved therapy. Right now, it's only available for a small portion of people with ALS that have this disease due to SOD1 variant. More hopefully coming soon. But even in the meantime, there's many potential benefits of a genetic diagnosis beyond treatment. And so if a person with ALS undergoes genetic testing, there's 3 main ways that results can come back: positive, negative, or uncertain. And the breadth of testing that will be offered, will be tailored to you based on your own individual situation. But typically, we look broadly at genes we know can cause ALS, often in what's called a panel, where you look at more than one gene at the same time. A positive result means a cause was identified, and that provides the most information. That's what we were just talking through: information for the person diagnosed and information for the family. If the results came back negative or normal, it would mean that we didn't find a genetic cause. And it doesn't completely rule out the possibility of a genetic component, because new genes can be linked to ALS over time, and that's something that can be revisited over time. And that is the more likely outcome when there is no family history. And sometimes we can find uncertain variants on testing, which means we've found differences in the DNA code. We just don't have enough data to prove if those are contributing to disease or if they're totally normal. And sometimes there's more things we can do to try to clarify those variants. Sometimes they remain uncertain for a while. A genetic counselor would help you understand that. And typically, we don't recommend family members test for something uncertain because if we don't know what it means for the person diagnosed, we won't know what it means for a person's risk. And so, how can genetic testing data that you all generate from undergoing genetic testing, if you choose to do that, actually inform therapeutic development? So, I already spent some time mentioning the fact that there are some FDA approved, there's one FDA approved therapy that's gene targeted, and there's some other ongoing clinical trials. I've listed some other examples here. And so those are ways in which having a tested population, people undergoing genetic testing for ALS, you're informing the development of therapeutics by allowing gene-targeted trials to be performed. If we have gene-targeted clinical trials, but nobody knows their genetic status, nobody can enroll in those trials. And so by undergoing genetic testing and participating in clinical trials, you're advancing the science for the further community. But interestingly, another sort of pathway that's emerged is there are some genetic variants that are more like risk factors, where it's not the genetic difference itself that causes disease alone, but it can certainly increase risk. And there have been now some clinical trials in development to try to target these risk factors that we think may be more broadly applicable to people with quote unquote sporadic ALS, people without a strong familial form, because these are part of the pathway of ALS pathology that may be more broadly applicable. So the SOD1 variant, the genes targeting SOD1 are, sorry, genetic therapies targeting SOD1 are only going to help people with SOD1 ALS. But the concept of some of these risk factors is therapies targeting some of these risk factor genes may be more broadly applicable to people with ALS in general, not just with one specific familial form. And so, by having genetic testing and participating in these trials, literally this data is contributing to the development of therapies. And so it's another important reason to consider testing. So you may ask, what does genetic testing actually involve from a logistics perspective? So testing can be done on blood, buccal, which is cheek swab, or saliva, like a spit kit. Most often these days it's done on buccal testing. Typically, to get results, it takes about 2 to 4 weeks for the most standard type of testing I was referring to, like a panel test. But if you do broader testing that looks across more genes, it can take longer. If you pursue testing through research, which we'll talk about in a moment, you may not ever get results back, or it may be longer to get results back depending on the protocol. So that's an important thing to consider. If you go through clinical care, the cost of testing is often well covered by insurance these days. It might be $0 out of pocket based on your insurance plan. It could be several $100s if insurance doesn't cover it. For that panel testing, the more basic testing that we often offer. But sometimes there's no cost sponsored genetic testing programs available where you can go through clinical care and get a no cost test because a pharmaceutical company has sponsored a program where you can contribute some of your data to their study in exchange for no cost clinical testing. And there may be other research methods to get testing as well. And when that's pursued, usually the cost of testing is covered by the study. When you do clinical care, it's just like any other medical test. This is something that a clinician orders. You submit a sample through that clinician. The results come back to that clinical team. The cost goes to you or your insurance, and then the results have your name and date of birth and are kept in your medical chart. On the research side, you may be able to access testing, but the goal of research is actually to advance science rather than provide you with information. And so it's important to ask about the protocol. Does this allow for return of results from the researcher? Is it what we call CLIA certified, where you can actually get the details because we know it's been done in a regulated lab, versus is it a research only test and you might not be able to get details back of your testing. One of the key differences about research is that cost is to the researcher rather than to you in most cases. And also, usually the results are done under a research ID number and kept in a research record rather than in a medical chart, which can have important implications for insurance and privacy considerations that are more relevant for at-risk individuals than for a person diagnosed. Some people ask, what are the limitations here? If genetic testing can help me and you're talking through all the benefits, why would I not do it? What can this not tell me? And so a few common misconceptions I want to point out is that if you go through testing and your results come back negative, for some people, they say, oh, That means it's not ALS. And I wish that was the case because I would have the best job in the world if I was the one taking away the ALS diagnosis. But unfortunately, that's not the case because we know that many people have ALS without a single genetic cause. That's the reason why they developed it. So a negative result does not mean it's not ALS. As I've mentioned before, a negative result also doesn't completely rule out the possibility that there could be a genetic component. But for some people, a negative result feels like a relief for family because we didn't specifically identify something that increases their risk. But if genetic testing is negative, it leaves many people wondering why they developed ALS. And for most people, we can't pinpoint what that is. As I mentioned before, it's possible to get uncertain results on genetic testing. And uncertain results can remain uncertain for a long time, even indefinitely, if there's not other people that have similar variants or the same variant found, or if there's not clear follow-up we can do to clarify it. A positive result, so finding a genetic difference, may not always lead to medical management changes or research options. I've mentioned there's one FDA-approved therapy for SOD1, and there's several ongoing research trials for some other genes like SOD1, FUS. There have been some for C9orf72, but there's not ongoing trials for every gene linked to ALS, and that's a constantly evolving target. And even a positive result doesn't provide a perfect crystal ball answer with regards to what to expect for the future. So we can tell you this gene can also cause FTD or can also cause Parkinson's, or people tend to live X amount of years or, experience, X, Y, or Z symptoms, but we can't tell you perfectly what to expect for your own future. And of course, any of these types of results can have emotional impact, which is why genetic counseling is so important. Some people may wish for a positive result because they're really hoping for access to that drug, but they may on the same vein be feeling really anxious about what that would mean for their family. Some people may be really hoping for a negative result because they don't want family members to be at risk, but at the same time, not expect the disappointment of not having access to a research opportunity or an approved therapy. And so enter genetic counseling. What can a genetic counselor do for me? Who should meet with a genetic counselor? I'm briefly going to go through this, and I'm keeping an eye on time. So, first of all, what the heck is genetic counseling? This is really a process of helping people understand and adapt to both the medical and the psychological, as well as the familial implications of genetic components of disease. So, meeting with a genetic counselor entails collecting a family history and using that to assess what's the likelihood of there being a genetic cause here. We call that a risk assessment. Educating, answering questions about what are the genetic forms of ALS? How likely is it that my ALS is genetic? What are my testing options? What would the implications be? A lot of the things that we just talked through today, getting connected with the appropriate resources and research, and helping people really make a decision that's best for them. The genetic counselor's job is not to convince you to test or to not test, but rather to help you make the decision that's best for you in that moment with the information you have on hand. And so pursuing genetic counseling does not mean anyone has to have genetic testing by any means. Those are two separate things. But genetic counseling is one way to learn more about genetic testing and ensure that you're making an informed choice. And so really, anybody who has questions or thoughts about genetics should be able to access genetic counseling if they want it. You do not have to have testing if you have counseling. And if you've already had testing in the past, you could still have genetic counseling to refresh on what's current or to answer questions or address issues that have come up for you. We know that coping and family dynamics and communication and other resources are another main reason that people access genetic counseling. It's not all about the genetic testing. Before someone thinks about testing, a genetic counselor is in a good position to help you explore some of the things you should think about first, like, again, what's the likelihood your ALS could be genetic based on what we know about your family history? What are your motivations and your goals for testing? What are you hoping to do with that information? What hesitations do you have? Are there things we can talk through that, would either give you comfort or, reinforce your hesitation and make you choose not to proceed? Clarifying, some of the misconceptions. What can you and can you not learn from testing? Who would you share this information with, or who would it be important to share this with? Who else could be at risk or affected by this information? Helping you figure out what's the right time to pursue this, right? If you know you want to test, but you're in the middle of figuring out, other equipment needs, or you're just wrapping your head around the diagnosis and you want to take a beat first, these are things we can help you talk through. Or if you're really motivated to join a trial or get access to a treatment, maybe then we say, okay, let's get this process started sooner than later because we know the sooner you start that, a trial or a treatment, the more likely it is that there could be an effect. Figuring out your support system and what resources you may need. So these are all things a genetic counselor can help you explore. To prepare for a genetic counseling visit, you should think about, family history. So has anybody else in the family had ALS or related neurologic conditions, and gather some more information about, details of their experience. And if anybody's had genetic testing, it's really great if you can try to track down a copy of their genetic testing reports to bring with you. Of course, compile your questions for the counselor and your support person or people. The more ears in the room, the better. And how do we access counseling and testing? So I wish that there was a genetic counselor embedded within every neurology clinic. That would be my dream. If I had a magic wand, I would make sure that everybody had access to genetic counseling and the option for low cost or no cost testing, but that's just not reality at this point. And so for some people, you may be able to access genetic counseling right within your ALS clinic, right within your ALS team. If you don't have an ALS counselor embedded in your team, you can ask your neurologist or whoever your provider is for a referral to genetic counseling. You can locate a genetic counselor yourself using the Find a Genetic Counselor tool, which I've linked here. And in the meantime, if you can't get access to a genetic counselor clinically, you could also explore accessing this through research. Some research protocols, like the All ALS study, for example, have the option to access genetic counseling with or without testing. And there's also some educational tools like decision aids through the Les Turner ALS Foundation that I've linked here that can help you think through, your goals and what your concerns may be to prepare you for that conversation with a neurologist or a genetic counselor. But please, if you have family members or you're a person with known risk but not, diagnosed with ALS, please don't seek predictive genetic testing without having genetic counseling first, because again, there's a lot of legal, privacy, discrimination, insurance, and also emotional considerations before proceeding with predictive testing, especially. I've compiled a set of resources here that I hope the IMALS group will share with you after today's webinar. And I also just wanted to go through a few take-home points. So to summarize, the majority of ALS does not have a single genetic cause. So most people won't have a positive result on testing. But this can be the case. You can have a genetic cause found regardless of whether you have family history or not. It's more likely to find a genetic cause if you do have family history. But genetic testing is available, genetic counseling is available. Having genetic counseling does not mean you have to have genetic testing. And whenever possible, going through that symptomatic testing, that diagnostic testing of a person with ALS puts the family in the best position to then provide information to individuals who may be at risk. So to hammer home the point specifically for a person without family history, which is the case for most people with ALS, we can still find a genetic cause more than 10% of the time. It can still provide an answer to why disease developed, even if it's not getting you access to treatment, approved therapy or an ongoing trial, but those are also possibilities. It can help us plan for the future and provide some information about what to expect. It can provide information to the family, and it can contribute data to the greater scientific community that can help advance therapeutic development. So I know I've just done like a very quick overview of very tough to understand sometimes information that can get pretty detailed pretty fast. And so I'm happy to answer questions, for the end of the webinar now. And I hope that this conversation can continue even beyond today.
Thank you, Lainey. There are a couple of questions in the chat. The person identified just as an iPhone says, they might discover genes that contribute to ALS. Can my DNA stay available for future testing so my children might have that knowledge in the future, if that makes sense?
That makes perfect sense, and that's an excellent question. So what I didn't go into is a couple of different things that address that question. One thing you can consider is if you participate in research, sometimes researchers will be able to hold on to that DNA and continue to do updated analyses over time. Whether or not your family members can access those results depends on the research protocol. But there's also something called DNA banking that can be available outside of research. There used to be one commercial lab that offered it in a really easy way, and now we have a couple of small academic labs that we've drawn on to access this, but it's called DNA banking, and that's the secure storage of your DNA, usually for a one-time fee, that then you can delineate who has access to the sample over time. And so if new genes get linked to ALS over time, your family members have access to that sample to get updated testing performed. And lastly, there's also something called exome and genome sequencing, which instead of looking at like a focused panel of about 30 or so genes that we know can cause ALS, actually looks across nearly all 20,000 genes in the genome. And that once the lab spells out that DNA code and runs that analysis, they actually hold on to the spelling code. And so that can be reanalyzed over time as new research is done, as new genetic causes are identified. That can be reanalyzed without having to submit a new sample. The limitation is that if we get a new technology for testing, we can't then reperform that, a new test on a sample because they're just holding on to the spelling code, not the sample itself. But that is another way that sometimes people will think about preparing for the future is if you undergo that broader testing, which is more expensive. It can be about $2,000 if insurance doesn't cover it. Um, that's one way to provide information for the family because then that lab can at least reanalyze the DNA code over time.
Thank you.
Mhm.
And there's a question from Yvette, who performs the genetic testing?
Yeah, it's a great question. So there's many specialized genetic testing laboratories that can perform the testing. Some examples in the US are labs like GeneDx, Prevention Genetics, Invitae. There's many different labs that can do this type of testing, but it would be important to use a genetic testing specialized lab that has, expertise in ALS. And that's something that the clinical care team would sort out for you. That's not something you have to determine yourself.
And if it had another question, which I think you answered, how does one obtain oh, no, sorry. This
Mhm.
question was, how does one obtain genetic counseling? So would that also be, you said for the testing, you would talk to your neurologist or your ALS clinic care team. Would that
Mhm.
be the same for counseling?
Yeah, so you can ask your ALS care team for a referral to a genetic counselor, or you can use that link that I had in the slide for the NSGC, the National Society of Genetic Counselors, Find a Genetic Counselor tool to locate somebody near you. We have genetic counselors throughout the US and throughout the world, but access to them can vary based on what state you're in and even what part of a state you're located in. And so there may be some people that can see you only if you come in person, but there's also many genetic counselors who are able to do remote or video visits. And there's actually even some telemedicine genetic counseling and testing companies where you can be anywhere in the US and access virtual genetic counseling. So one such example is a company called Synapticure, which is actually ALS specific. But there's also Genome Medical is a telemedicine genetic testing or telemedicine genetic counseling company. Gray Genetics is another. And so you can access virtual genetic counseling through one of those services if you don't have a genetic counselor on your ALS care team or if your neurologist or ALS provider doesn't know who to refer you to.
All right. Question just dropped in the chat. If uh, if I were to do if I were to get genetic testing, what would you be tested for? What if you don't have an ALS center backing?
Yeah, so part of the reason to meet with a genetic counselor or a neurologist or other provider with genetics expertise is they would help determine what's the most appropriate genetic test for you to have, what should be covered. And so for most people, the first step is what we call a panel, which looks at more than one gene at the same time, which typically includes the 30 or so genes that we know are most commonly linked to ALS at this point and includes repeat expansion testing for that C9orf72 gene I mentioned is the most common genetic cause of ALS and FTD. We mentioned that separately because in addition to looking at the spelling code of that gene, the testing has to look at the size of it. In fact, the size is what's the important part for that gene. So that might be listed as a separate test, but your providers would offer you the appropriate testing based on your diagnosis and your family history. Sometimes broader testing may be recommended if your diagnosis is a bit uncertain. If it's like ALS versus a motor neuropathy or ALS versus something else, there might be other genes that are worth including. And so that's why, a provider would help you figure out what's the best testing strategy. If you don't have an ALS center, an ALS team, you can ask your primary care provider for referral to genetic counseling, and then they can set you up from there.
Thank you. That answered another question that was just put in the chat. So you covered two topics there. Thank you.
Great. Yeah.
We are up to date with, oh, here we go. Yes. We are up to date with the questions in the chat. If anybody wanted to ask a question live, if that's easier for you than typing, feel free to take yourself off of mute and you could ask a question live if you'd like.
I also see one while we're waiting. Oh,
Yeah,
sorry.
actually, sorry, it's
Go
faster for me
ahead.
to ask than type. Apologies if you've mentioned this, but besides offsprings, in particular with ALS, would you recommend siblings, or who would you recommend if a patient, sorry, I'm a physical therapist, if a patient of mine has ALS, would you recommend not just their offsprings, but their own siblings, so that the children of those siblings, I didn't know sort of if it went sideways versus just down the line.
Yeah, so whenever possible, we recommend that the testing process start with a person with ALS, a person with the diagnosis, because we can test them broadly for the genes that we know can cause ALS, and then we can see if we identify a genetic cause or not. If we identify that genetic cause, then the genetic counselor would help the person understand who else in the family may be at risk. And so, certainly biologically related children, biologically related siblings, and then sometimes extended family members who may still be living, like parents, aunts, uncles, cousins, etc. So, it really depends on the family tree. Sometimes it's possible that a person is living with ALS and both of their parents are living and don't have ALS, and we may recommend testing the parents to see which side of the family tree has the risk, but then that parent has to be comfortable with learning their risk status. So that's something that, we navigate. But certainly we think about the family as the unit, and it's not just up and down the family tree, as you said, it's side to side as well. But what the risk percentage is depends on, where you fall in that family tree. So we would help figure that out. I also just wanted to address a similar topic that is the one I was looking at in the chat, which is the question is if somebody passed of ALS and then a family member wanted to be tested. So again, on this concept of who in the family has risk. If a person with ALS passed and didn't have genetic testing, and then family members want to know their risk, technically it's possible for us to do broad predictive testing for the genes we know can cause ALS, but it's actually quite limited in what we can tell you about what those results mean. Because if we don't know the cause of ALS in the family, and then, daughter undergoes genetic testing broadly for genes that cause ALS, and the results are negative, we can't actually completely rule out risk of ALS because we don't know what the cause of, let's say, mom's disease was. So if mom passes with ALS, never had testing, and then daughter gets testing and tests negative, we don't know, did mom have a genetic form and daughter just didn't inherit it, so it's a true negative? Or could mom have had a genetic form and a gene we haven't linked to ALS yet, and daughter's results don't mean anything? And if we get an uncertain result, there might not be much we can do to further clarify that. So it's possible for family members to access testing even if the person with ALS didn't test, but it's much more informative if the person with ALS undergoes testing first.
So then this may be a little bit too complicated and getting in the weeds. So if somebody with ALS gets a testing and they're negative, is there reason to continue testing and moving on to the offsprings regardless of the negative test, or not
Good
so
question.
much?
Good question. So it a little bit depends on the family, but generally no. So
Right.
if a person with ALS tests and tests negative, there's nothing that we're gonna be able to recommend family members test for to further clarify their risk because we
Right.
don't know cause of disease in the family. But if the person with ALS tests negative and there's a very strong family history, or we're still very suspicious that there could be a genetic cause, there may be additional testing we recommend for that person diagnosed. And we may still counsel family members that even though the results were negative, we still consider them to have an increased risk of developing ALS based on their family history.
Thank you very much.
Of course. Thanks for the question.
Pete, you have your hand up?
Yeah, thanks. This, boy, is one of the, obviously the more exciting, well, it is an exciting technology. on development and possible treatment, as you mentioned early on.
Mhm.
So I'm curious, as computers get faster and AI, whatever you want, do you see, Lainey, new advances? Because I remember I've been around a while, and when they, oh, we finally, mapped the genome of a mouse or whatever it was, and now we're doing it with humans. So are there things on the horizon that would make this move even faster?
Yeah, so it's a great question. I know that the big frustration is that it feels like not much has changed up until I would say like 3 years ago. Not much felt like it changed in ALS research and care for a long, long time. Right now, we've had tofersen's approval and there's more trials going on so that you can feel the progress. I would say I think things do feel like they're accelerating with, new technologies like, certainly AI will have influence on, I'm sure, like clinical trials. People have talked about AI control groups, for example, to speed clinical trials up. But also, there's just been a lot of proof of concept across diseases for different genetic approaches to therapies that may or may not be translatable to the non-genetic forms of ALS, but the hope is that they will be. And so, you may have seen in the news that actually at Penn and Chop, we just colleagues treated the first baby with a personalized gene therapy for a baby with CPS1 deficiency. And so there's going to be more and more development of these like individualized N of one therapies, I believe. And Dr. Neil Schneider at Columbia, through his Silence ALS program, is really championing that in the ALS space. And so I do believe that not only the technology that's advancing, like AI and whatnot, will help accelerate things, but also learning from other drugs that are showing promise in genetic forms of ALS, but also in other genetic conditions. I'm hoping that that will continue to speed things. But as always, that's a big fat question mark that is one that everybody wishes would, have an answer, a crystal ball, but it's hard to predict. Yeah, go ahead, Mike.
Oh, so you can hear me fine?
Yeah.
Okay, so I just want to kind of go over a few things. My sister died back in 1993 of bulbar ALS. She was 46. I guess the husband, who still alive, and we know him. I guess he had the test done, some type of test back in 1993, and he discovered something. I think it was just about then they discovered a certain gene. Is that correct? So my question to you is, now my brother, who is at 67 years old, has now developed symptoms of ALS. No family history at all. It's in his legs. So he's at Hershey Medical Center right now, kind of figuring it all out. And they want to know, my brother-in-law never said anything about this test back in 1993, but he knows the results. He didn't want to say anything because it affects the children, blah, blah, blah. So, and if he decided, if my brother called him and he said, hey, what was that test now that I have these symptoms? What would that tell? Anything? I mean, would it say anything about my brother's symptoms, which again is totally different? And the other last question is, how odd, and I know you hate sporadic, you don't like that, but how rare would it be, two sporadic cases in a family where there has been no history at all of ALS?
Yeah, so actually when two siblings get diagnosed with the same condition, that is family history, even if there's not anyone further back in the previous generations. And so having two individuals in the same family, whether it's two siblings, a parent-child, or a more distant relationship, does significantly increase the chances of there being a genetic cause. And so the person newly diagnosed with ALS can undergo their own genetic testing. So they don't need the relatives' results to be able to pursue their own genetic testing. But sometimes it can be helpful if we know the genetic cause of disease in a family to ensure that the laboratory completing the new testing is aware of what we think the genetic cause of disease may be in the family. And so I would encourage you and your family to pursue genetic counseling to talk about the nuances of your family situation further, especially because it could have implications for access to treatment.
Yeah, and I guess I'm part of this. He's my brother, so I mean, there's four siblings, so now this is number two. And again, there's nothing's confirmed yet, but it's looking kind of grim. But yeah, okay, well, that's good to know.
Yeah, and certainly I would encourage you to reach out to me or to another genetic counselor that's local to you, depending on where you are, to talk about that further and to unpack your family's individual situation.
Will do.
Yeah.
Lainey, you have some thanks in the chat. Susan Baker says, thanks, Lainey. Great info as usual. Hashtag end the legacy. Hashtag ALS FTD caregivers. Dominica says, yes, thank you, Lainey, for an informative and great presentation. And very early on in the presentation, if people didn't catch it in the chat, Mindy Yerlib posted that she has genetic ALS FTD in her family, and she has just written a new book, Last Nerve, a memoir of illness and the endurance of family, that's available on Amazon for people. Any last questions now that we're up at the top of the hour from anybody?
Lainey, are you okay with us sharing your slides? I know you had a few slides in there for resources. So either the whole presentation or just those resource slides for people to access.
Yeah, absolutely. I can send you a PDF of some of the slides.
Awesome. Thanks.
So as Julie just mentioned, there'll be both a recording of the presentation that will be posted to IMALS's YouTube channel, but then there will also be a PDF available with slides. And I know that Alyssa put together 2 other resource slides that Julie will include as well for people. So thank you, everyone. Again, thank you, Lainey, for taking the time to present such clear and informative, helpful information. And thank you, everybody, for taking the time and for your questions and your participation. Really appreciate it.
Thank you so much. When will it be uploaded onto the YouTube channel for IMALS? Do you think?